Hello, everyone. I'm Barbara Hamm Lee. It's Friday at noon, and it's time for another view on health. If you have a chronic, loud snorer in your house, the next hour may change your life. No more hunching and asking your spouse to turn over. No more pulling the pillow over your head for relief. And no more sleeping in another room. My co-host, Dr. Keith Newby, is here, along with Dr. Demi Barot, an expert on sleep apnea, what it is, why it happens, and how it's treated. We'll get help for you so that you can get a good night's sleep next on Another View. But right now, it's time for news with NPR.
Discussing today's topics from an African-American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Hamm Lee, and I'm joined by my co-host, Dr. Keith Newby. Hi, Keith.
How you doing?
I'm doing great.
Wonderful.
It's the fourth Friday of the month, the time when we talk about health issues, and we've got some help for you or someone you know you love if they suffer with sleep apnea. We're going to get to that in just a moment. But first, for the past 5 years, the Hampton Roads Prostate Health Forum has been aggressively reaching out to educate men and women about prostate cancer and encourage men to get tested. It's a disease that affects all men, but is prevalent in the African American community. It can affect all men, and is prevalent in the African American community. It takes a village to get results, and joining us by phone is Keith Gregory, Vice President of the Hampton Roads Prostate Health Forum and Executive Director of the Hampton University Proton Therapy Institute. Hello, Keith. How are you?
Hello, I'm fine. How are you?
Good, I'm doing fine. I know that's a long title.
There's a lot of Keiths on the phone right now.
Yes, there are.
Or on the radio right now, so I hope people don't get confused.
Okay, this is Keith Gregory we're talking
Right.
to right now. But Keith, I want to ask you a question because normally we have Charlie Hill, he's one of our favorites, on to talk about prostate health and to talk about the activities that you all are involved in. This is the 6th year, if I'm not mistaken. And I'm just wondering how the outreach has been. Are you reaching more men? Are more men paying attention?
Well, every year we reach more and more men, and our goal is to try to reach all men, but particularly African American men in the community. And we have held events over the past few years. Screening events, or as politically correct, are early detection events around the peninsula and Hampton Roads, and trying to encourage men and the women that are in their lives to bring them to these events so that they can learn more about prostate health and prostate cancer and the need for early detection as a way to save their lives. And we've done these events like this, like I said, over the past few years, and had hundreds of men that come. We have men that come to the events religiously as a way to get their screenings done that know about it, but we're always trying to get more men to become involved.
Is there a cost barrier for people in terms of getting screened?
If you're not insured,
Yes.
there's always a cost barrier. I think most men. I think if there was a psychological barrier that's bigger than the cost barrier,
Okay.
because we as men, and I include myself, but even though I do go get tested regularly, tend to not go to see a physician annually for just the regular checkup. And what we're always trying to encourage men to do is to get their regular checkups, particularly African American men. And particularly to make sure that the physician that they are seeing does a PSA and what's called a DRE, the digital rectal exam, because African American men are at a higher risk. There are many physicians in their training that don't promote doing the PSA or the DRE for men until they're over age 50. Which, with the Prostate Health Forum, we are recommending that African American men at least get a baseline PSA by no later than the age of 40. So, because these tests, as I said, offer a baseline, because a PSA was a number, and that number needs to be tracked to look for change.
To look for
even
changes.
if it's normal.
Keith, do you have a question? Keith Newby?
One of the questions on your event, is it next Saturday?
It's on the 6th of September.
Okay.
Yeah.
All right.
2 Saturdays.
Yeah. Okay. Great. I was going to say one comment. If we could get some information, I'd love to post some of this in the office and give it to some of my other physician colleagues to make sure people are aware of the event itself.
Right.
So and I'll just get you my email off air. And maybe
Absolutely.
you can send that to
I'll
me.
make sure I get that to you.
Okay.
Perfect. Well, since we brought up the walk, let's talk about that. What's going to be happening on Saturday, September 6th?
On Saturday, September 6th, we're going to have a prostate cancer awareness walk. This is, I believe, our 5th annual walk. And what we do is we do that to raise awareness. And in concert with that, we usually have some type of educational event. And so we will have a seminar here it's at the Hampton University Proton Therapy Institute here on Enterprise Parkway in Hampton. People need to understand if they can go to our website and get the information about where we're located. We are not on the campus of the university. We are at the exit, which is the exit if you're coming from Williamsburg, the exit before Coliseum Drive, and we're the Magruder, or the exit after Coliseum Drive if you're coming from the south side direction. And we are in a very beautiful location in an office park here. And what we are going to do at that event, we're going to have the memorial, we're going to have the awareness walk, and some people jog it if they would like to, and it's only a mile. So it's not a long thing. We're not trying to help people get their weekly exercise in if they want to. It's more about awareness. And getting African Americans, particularly, to come out and join this walk. We are going to have we are going to recognize the fraternity and sorority and the community groups that have the largest turnout. So we try to turn it into a little bit of a competition.
Oh, okay.
As you
so
may
you
or
can
may
put
not
together
know,
your own team.
You can put together your own teams, and so we're going to recognize the largest teams at the event, and then we're also going to later on present those teams with a plaque later on after the event. We'll come to that organization's meeting place and present a plaque to that organization. Mr. Hill is a member of the Omegas, and they have to say that they have always had a large turnout for this event. And
so is Dr. Keith Newby. So
we got Newby, your guys are well represented, and I'm a member of Kappa Alpha Psi, and any of my brothers that are out there that are listening, I encourage them to also show up in great numbers, and also with the other fraternities and sororities, the Sigmas, the Zetas, the Deltas, the AKs, and so on and so forth.
Now, there also is going to be prostate cancer screenings for the first 100 men?
That's right. I was getting to that. We're going to screen free of charge the first 100 men that show up that want to be screened with both the DRE and the PSA. We will contact them within, as soon as we get the results, we will contact those men. We have 2 physicians that are going to be here along with their staff assisting with getting those done. So with the DRE, the digital rectal exam, you'll get immediate feedback from the physicians for the results of that part of the test.
Okay, so the event is on Saturday, September 6th. It's a 1-mile walk run from 8 a.m. until noon. And if you want to register for screenings or the walk, you can call 251-6800, 251-6800. Keith Gregory, we wish you all the very best on September 6th. And I know you encouraged the significant female counterparts to the men who come along also.
Right. Drag them out kicking and screaming if you need to.
Okay, fantastic. You can also find out information about this on our website, anotherviewradio.org. Thank you so much for joining us. That's Keith Gregory. He is the Vice President of the Hampton Roads Prostate Health Forum and Executive Director of the Hampton University Proton Therapy Institute. And now for our other health topic of today, sleep apnea. It's a condition that's guaranteed to prevent everyone from getting a good night's sleep. The person who has it doesn't sleep well and may suffer with daytime sleepiness, along with others in the household who cannot sleep because of the loud snoring. The good news is that you can get help. So joining us to talk about sleep apnea is Dr. Demi Barot, Associate Professor at EVMS and affiliated with Virginia Neurology and Sleep Centers. Dr. Barot, welcome to
Thank
Another
you.
View. So
Appreciate
glad to
it.
have you here this afternoon. So, sleep apnea, first of all, snoring is one of the symptoms and usually the one that people most associate with it. But exactly what is it?
What is sleep apnea? It is a simple or layman's way of representing a group of sleep-related breathing disorders. There are a number of conditions that are part of the sleep apnea spectrum, starting with something like snoring and including all the way to something as extreme as what we call obesity hypoventilation syndrome, which is when you have heart problems, lung problems, body problems, oxygenation problems. But roughly, sleep apnea means interrupted breathing during sleep. The most commonly recognized and advertised or marketed, if you will, symptom is the snoring. I think we were talking off air a little while ago. While snoring is extremely important and usually a sign of something interrupting breathing, it's not the snoring that causes the problem. It's what happens after the snoring. So
Because you actually stop breathing.
or you have interrupted breathing, whether you stop or you have partial collapse of the upper airway. This is an airway disease. It's a neurological condition because the tone of the airway is actually mediated by the brainstem. So what happens is when people snore, if you've ever heard someone snore, because I know none of us does.
You're right.
The other piece is that we're unconscious, right? By definition, sleep is a reversible state of unconsciousness. So when people snore, they usually snore in what we call crescendos or waves. So it starts soft, and then it builds up, and then it stops. And it's that period after it stops that's the dangerous part. It's called the snore arousal. This isn't the regular arousal. This is one that that interrupts the brain's ability to get proper rest and go through the proper stages of sleep. So heart rate goes up, sometimes blood pressure shoots up, and when this happens repeatedly through the course of an hour, a night, for nights, weeks, months, years at a time, it can take its toll on other parts of our body, including our heart.
Now, are there two types of sleep apnea?
There are actually
Or
a
more
number
than
of
that?
types. Yeah,
Okay,
I
so
mean,
they're different.
Yeah,
But-
there's obstructive sleep apnea,
Right.
which is the one that everybody has
That's-
heard about,
okay.
that most non-sleep physicians would know about. And so when they send, for instance, a patient to be screened or evaluated, they'll put OSA, obstructive sleep apnea. There's also what we call central sleep apnea, which I think is to a certain extent more pertinent with our heart patients. And then there's something called mixed apnea, where you have a combination of obstructive events and central events. We could talk about the details, but in short, obstructive sleep apnea is when your airway collapses and then you make an effort to overcome that interruption. Central
And are
apnea.
you doing
yeah.
that conscious? I mean, that's your brain
It is-
telling you
it's
that
a
you
reflex,
need to do that?
It's a
Okay.
protective mechanism. So, for instance, you may have a pause in breathing that lasts for a minute or two, and ultimately it's almost like a panic button goes off in your brain to restart the breathing pattern. And when that happens, you have the restarting of whatever snoring or breathing pattern that you had before. And so it's not, remember, it's not just the pause, because that's when oxygen levels start to drop. It's also that panic response to turn it back on, because you have a surge of what we call catecholamines, or the stress hormones that we associate with the flight or fright response. So just like if you saw a boa constrictor on your neck and you'd freak out,
Yes.
imagine that there's a boa constrictor squeezing your neck and you keep freaking out throughout the night.
440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. Do you or someone you love have issues with sleep apnea or sleep problems? Give us a call, 440-2665 or 1-800-940-2240. So if you snore, does it mean you have sleep apnea?
It doesn't always mean it, but it is a very strong predictor. Most people who snore have sleep-related breathing disturbances. We used to think that not all that glitters is gold, so that if you snored, it wasn't a big deal. For centuries, probably, or for years at least.
You just push your spouse over and say, turn over.
Yeah, like roll him over or joke about it at Thanksgiving dinner. Oh, he's a sound sleeper because he snores like a freight train. But ironically, that can actually be the indicator that sleep is not refreshing and he's not getting deep sleep, if you will.
So the next day, what happens then? Because there is something called daytime sleepiness. Talk
right.
a little bit about that.
Well, believe it or not, fatigue and sleep disorders cause more motor vehicle accidents every year than alcohol and drugs combined.
Wow.
This is per the National Highway Traffic Safety Administration, which is the governmental body that assesses this type of epidemiology. What happens is because your brain is interrupted with having to restart these breathing patterns or cycles, your brain doesn't get adequate rest. It doesn't go through the stages of sleep. In short, there are 4 stages of sleep. There's N1, N2, N3, and REM sleep, which we've all heard of. REM is where the majority of our dreaming takes place. But incidentally, REM is also the phase in which people have the most severe sleep apnea. It's on their back and it's in REM. So people don't get to REM sleep. And one of the functions of REM sleep is to process and consolidate newly acquired memories. So one of the symptoms people have is difficulty with short-term memory. They won't always come to you and say that I forgot my keys because they're scared they may have something like Alzheimer-type dementia. What they'll tell you, or what their spouses will tell you, for instance, is that I have trouble recalling names or finding words. I'm about to say something and I just can't get it. I keep saying it's at the tip of my tongue. Or something that for instance, if you're a physician and you've written prescriptions of a certain medication with a certain dose, you find that you're befuddled because you're sitting there at the prescription pad and you're like, what's the name? What's the dose? Right. So it's the things that otherwise we have taken for granted.
We're going to bring you into this conversation, Dr. Newby. But when you see patients and they talk about, or do they talk to you about their snoring or their sleep habits?
Actually,
and how does that affect heart issues?
Rarely. Actually, what happened, part of what drew me into evaluating patients was we would get all these people with chest pain and breathing issues and all that. They'd come in and say, I'm short of breath, I have chest pain, and we do a cardiac workup, and you get a negative cardiac workup. And eventually I stumbled upon some data. This was several years ago. I've been referring for sleep studies since probably 2001, 2000. And,
because you normally wouldn't think of a cardiologist referring someone for a sleep study.
Well, I tell you, I always felt vindicated in my the thought process about trying to get people evaluated, because at the time I started referring people, it wasn't the correlation between heart disease and sleep apnea wasn't as well known, but I just kept running into this problem, and then I would send people off and find that they had severe sleep apnea, and then you start reading about it and seeing the correlation of cardiomyopathy development or weakened heart conditions, and you really think about it, what's happening when you think about the comments made about what's happening during sleep when the oxygen levels are dropping. Oxygen is what actually promotes all the bodily function, the chemical reactions, everything that promotes the good health aspect, everything about even coronary disease. What causes a heart attack is obstruction of oxygenated blood to certain areas of the heart. So if, and I always look at it as akin to like if you have like a train and you have the cars and you have some kind of some things you're putting on those cars. Look at those as oxygenated red blood cells. So those cars have to get the oxygenated red blood cells to an area. But if I start stripping the oxygenated red blood cells off before you even put them on the train, then you have less to transport around. And what I was finding is these people were having these daytime chest pain issues and shortness of breath issues because of the damage that was happening the night before, that every night it's the same thing over and over again. So that everybody just always say, well, y'all don't understand. When I'm during the day, I'm awake during the day. And I say, yeah, but look at it like if you cut yourself, it hurts. And it hurts immediately. So you put a Band-Aid or whatever on it. Every night you're cutting yourself. When do you have time to heal? I said, so you're always
killing me softly.
Yeah, exactly. With his song.
And not to interrupt you, Dr. Newby, but on that note, it isn't always that people who have sleep issues like sleep apnea will come or will be brought by someone in the family with complaints of things like snoring or even daytime fatigue. While those are common representations or manifestations, when you look at the host of chronic health conditions, including heart disease, that account for over 3/4 of our healthcare dollars, each of them is independently and primarily linked to sleep-disordered breathing, high blood pressure, congestive heart failure, coronary heart disease, cardiac arrhythmias.
Wow. And
if we get into some of this data Dr. Newby already knows about, it'll be very compelling for some of our listeners. Diabetes, 58 to 72% of type 2 diabetics have underlying, usually undetected sleep-disordered breathing. Obesity, stroke, mood disorder, sexual dysfunction, physical and mental health conditions have a strong link to sleep-related breathing disorders and sleep conditions. We used to think that there was a loose association, but as Dr. Newby suggested, in the last 10, 12 years, there's a very strong association, to the point that the American Heart Association has published landmark statements, including one that not only confirms that if you have high blood pressure and sleep apnea together, when you treat the sleep apnea, you improve blood pressure control with less medication, for instance. But if you treat sleep apnea in folks who are prone to developing high blood pressure or pre-hypertensive, you can actually prevent the onset of high blood pressure.
That is true. I see that. I mean, I see that clinical practice. That is a very strong, true statement.
440-2665 or 1-800-940-2240. Gary joins us from Chesapeake. Hi, Gary. You're on the air.
Hi, yes, I'm here. Can you hear me?
Yes, we can hear you.
Okay, I found out I had sleep apnea about 7 years ago. I found out I stopped breathing 293 times a night, or while I was taking the test. I got a CPAP, and I'm doing great now. The thing I'd like you to mention that's not mentioned a lot in these type of things is that a lot of people will take sleeping aids to try and suppress. They feel they can't sleep, so they'll take over-the-counter sleeping pills and all this and that, and it winds up killing because you're breaking down that defense that the brain has to wake you up.
What? Just before you go, Gary, I'm just curious, what sent you to get tested in the first place?
I had a minor surgery, and the doctor said afterwards, he said, you have the worst sleep apnea I ever heard while you were under anesthesia. We could hear you 3 hallways down.
Wow.
And I got a sleep study and found out I had this, got a CPAC, and I live by my CPAC, man. I'd shoot anybody who tried to take it.
Okay, thanks so much, Gary, for the call. First of all, we need to explain what a CPAP is. And also, but the issue of using medications, over-the-counter medications, or asking another doctor who may not be aware for sleep medicine.
Well, amongst the symptoms like daytime fatigue and snoring and mood disorders and memory loss and so on is the very common prominent symptom of difficulty sleeping, or what we call insomnia. That may be difficulty falling asleep, it may be difficulty staying asleep, it may be a combination of both, which it usually is. Insomnia is one of the most common manifestations of sleep-disordered breathing. But when you look at the population that reports difficulty sleeping or insomnia to a healthcare provider, the vast majority of them actually get these sleeping pills. And we've all heard of them, Ambien CR, Lunesta. Now there are a few other ones. It's funny how when the generic, or when the brand starts to become generic, you start to see new ones pop up with sustained release or extended release or whatever. And it happens in every drug category. But ultimately what happens is, just as this gentleman suggested, as Gary suggested, we pepper these symptoms with these medications, and what we find long term is that these medications don't work. In fact, if they help at all, they may help for 1 or 2 or 4 weeks, and then just as with any other symptom that you pepper with medication, you have to raise the dose, and then you have to switch them to a different brand name or to a generic or whatever. Ultimately, the majority of folks who have complaints of insomnia get prescribed a pill. But ironically, the majority of folks who complain of insomnia don't have what we call primary or psychophysiological insomnia, for which those pills are FDA approved and indicated. So we're treating symptoms, we're putting a Band-Aid on the bleeding without looking for the vessel itself, and ultimately all we're doing is prolonging the inevitable.
Let me take one more call, and then I want to get into the treatment for sleep apnea. 440-2665 or 1-800-940-2240. Join us in our conversation. We're talking about sleep disorders, and Rusty joins us from Chesapeake. Hi, Rusty. You're on the air.
Hello there.
Hi.
How are you?
Okay.
My question was, is there any simple mouthpieces that could help with this breathing that you could sleep with?
Okay, we will take care of that question right now as we get into the treatment for this.
Exactly. So CPAP, just to explain, it stands for continuous positive airway pressure. It was co-invented about 35 years ago by Sullivan and Rappaport. It was a breakthrough because up until that point in time, the only way to really effectively treat sleep apnea when it was detected was to do something called a tracheostomy, which Keith remembers. You actually have to cut a slit in the throat and create an alternative breathing pathway.
Okay.
So even to this day, I've told patients who say, I really can't sleep with my CPAP, or I don't want to deal with it, or I feel suffocated. We can get into why they feel suffocated too. Is sometimes I'll tell them, you stop breathing 100 times an hour. There really isn't any other primary effective mode of therapy, if you'd like, because, whatever reason, you have diabetes, you weigh 300 pounds, whatever, we can do a tracheostomy, and all of a sudden, magically, everybody wants to use
that CPAP, absolutely.
But to answer the question, so it's actually PAP that we're talking about. So PAP, positive airway pressure, this is an air splint that through the use of a nasal or an oral or a nasal oral mask or interface, we're using this interface and then a pump. It's a flow generator that this machine takes room air, it compresses that air, and it delivers it through this mask. And when it does that, it splints the airway open when it would otherwise collapse. So consequently, the airway doesn't partially or completely collapse at all, and the airway is wide open if the CPAP is prescribed properly.
Keep breathing.
Right, but there are other modes of ventilation. You probably have heard of BiPAP, bi-level positive airway pressure, which means there's a higher pressure when you breathe in through the machine and a lower pressure when you breathe out. Most of the good newer CPAP devices that are out there are what we call auto-titrating, which means they automatically can adjust, almost function as a treatment device, as a treatment study, and they have the ability to change the pressure when you breathe in versus when you breathe out, because some people find it uncomfortable to exhale against a fixed pressure.
It's not the sexiest thing in the world.
Well, it didn't used to be. I wouldn't go so far as to say that it is a rock star sexy, but the machines are way different than they used to be. They used to be big tanks that made a lot of noise and definitely wasn't something you wanted to advertise when people came over to see your bedroom with these masks that look like Darth Vader. But times have changed. The machines are now literally, they're this big. I'm showing you,
He's showing us about the size of, maybe an iPod docker.
That's right.
Docking
That's
station.
right. And, with the humidifier, it's not much bigger. These things are less than 1.5 pounds. They look very sleek. Some of them look like a little Bose stereo. The masks aren't even masks anymore. Some of them just plug into your nose, so they actually look like a fatter nasal cannula, which is what you guys have seen and what our listeners have seen related to supplemental oxygen.
Right. And they're really quiet, too.
Extremely quiet. I mean, I wear a CPAP just because I want to, but I open my mouth to sometimes check if the machine is on. That's how quiet it is.
Wow, well, I'm going to have to tell my husband he needs to get a new one. Because his is not quiet.
And just to answer this last caller Rusty's question about mouthpieces, so what I think he's describing are these oral appliances that sometimes you hear certain dentists advertise that they can make for patients. Remember that the oral appliances, the sleep apnea surgery that used to be done so commonly, these in general are not what we call primary modes of therapy. Now, for certain select patients, and patient selection is key in just about anything you do, you can use for folks who either don't want to or don't tolerate CPAP for whatever reason. For instance, in people who have mild or mild to moderate obstructive sleep apnea only, for a qualified dentist, somebody who's trained and is a diplomat of the American Academy of Dental Sleep Medicine, they can actually fit almost a retainer-like device that slowly pulls the lower jaw forward. So the idea is that if the lower jaw, the mandible, is pulled forward even by a few millimeters, that prevents what otherwise would be collapse of the upper airway.
If you're just joining us, we're talking about sleep apnea with my co-host, cardiologist, Dr. Keith Newby, and Dr. Demi Barot, the associate professor at EVMS, and with the Virginia Neurological and Sleep Centers. Woo! Neurology and Sleep Centers. There you go.
Try to say my first name.
Maybe I know. Absolutely. 440-2665 or 1-800-940-2240. Maury joins us from Chesapeake. Marcy. I'm so sorry, Marcy.
That's okay.
Go ahead with your question.
My husband, he has every bit of the symptoms that you're talking about. He has the fatigue. He has the tiredness. He is slightly overweight. He has tried the CPAP because he's been known he has been told that he does have sleep apnea. He's very claustrophobic, so he refuses to wear it. So he is using what's now called a mouthpiece to help him not snore. And I think all he's doing is putting a Band-Aid on it, like you guys were just explaining. And it's really making me nervous because his snoring is just atrocious. I have to we sleep in separate rooms, and it's sad.
Wow, Marcy, that's thank you for that call.
You know,
Dr.
we
Barot.
hear these kinds of things. Marcy's not alone. You know, some time ago I contemplated writing a book about my experiences. I know I'm not the most experienced guy in the world, but enough to know that, for instance, marriages can fall apart. People sleep in separate bedrooms. And I wanted to write a chapter about a husband and wife who otherwise love each other, but their personal time, their bedtime is interrupted by something like this. Marcy, you're not alone in the sense that a lot of folks are getting what really should be more optimal treatment. And the funny thing is, the ironic thing is that the majority of time that people say that they can't tolerate CPAP or PAP, it isn't a big deal. It's usually something that's very straightforward and almost simple for a qualified, trained, board-certified sleep doctor to be able to address. Something as simple as, oh, well, I feel like I'm being suffocated with the mask on. Now, the physiology behind the suffocation is that when you're unconsciously struggling to breathe during sleep, you almost develop a PTSD, post-traumatic stress disorder type response. So when something ironically is supposed to be helping you sleep, but it happens to be on your face or in your nose,
It's making you even more anxious.
you become panicky. And the way to be able to combat that is the way that you would combat any phobia. Like we learned in med school, you don't treat phobias always by flooding people and saying you have to wear it and that's just the way it is. You do what's called systematic desensitization, which is if I'm scared of snakes, then you're not going to flood me with a king cobra so that I get over my fear. You might start by showing me a black and white picture of a garden snake. Then you might progress to a color picture. Then you might take me to a pet store and let me see it in a glass cage with everything locked. Then you may take me to another place where in a zoo, not everything is locked, and I look at something that's a little bit potentially more fear-inducing, like a boa. Ultimately, if it's important enough for me to want to get over that fear, then there is a slow, methodical way to be able to address that. It's the same thing with CPAP. We actually have a CPAP desensitization protocol in our clinics because we know about this. And ultimately, when you go through these types of pathways where people can slowly get desensitized to what they need to because it's important for their health, the treatment can be very successful. Sometimes changing the mask, sometimes addressing a leak, sometimes addressing mouth breathing, pressure changes. I have trouble breathing out against the pressure, so you lower the back pressure or the expiratory pressure. So all these things that are otherwise potentially fear-inducing can be addressed very straightforwardly. And so the key in all of this is the follow-up. Anybody can do just about anybody can do a sleep study, but are you going to hound that patient and work with him or her until you do whatever it takes to get over this fear or this phobia?
Let's talk about the sleep study for a minute, because that's the first step, is it not, in terms of trying to get to helping you to get through your sleep apnea.
Well, you say the sleep study or the evaluation first.
Okay.
I would say that the sleep evaluation is probably the most important part of all of this, because the qualified sleep healthcare provider is the one who can then navigate your care and hold your hand, so to speak. Because as was it Sandy?
Yeah,
Or Marcy, yeah.
Marcy.
As Marcy described, I know this. She's the only one who has this problem about men being stubborn and difficult to deal with. But you know, the biggest barrier, as I was telling you earlier, to being able to help people with sleep disturbances is really helping to overcome ignorance or a lack of awareness. When you become aware, for instance, if you're a type 2 diabetic, or your doctor says, listen, you're pre-diabetic and your blood sugars are creeping up and you need to keep an eye on them, and you need to diet and exercise and watch what you eat. Well, duh, right? I mean, we know that, and we have dietitians and nutritionists and protocols and so on. But not everybody who wakes up in the morning decides, hey, today I'm going to go eat at a fast food restaurant and I'm going to gain weight or I'm going to increase my blood sugars. There's a physiology. That's right. There's a physiology. The brain is dependent upon healthy, restful sleep, and consequently, that healthy, restful, consolidated sleep releases certain fat and appetite hormones. And when you don't get quality sleep, you distort the secretion of those hormones like cortisol, leptin, ghrelin. So you become abnormally hungry. You crave carbohydrates and fat-rich foods instead of leafy green vegetables, and you eat more, and your satiety hormone release is
People
affected.
don't really understand how much sleep affects the entire body. I mean, and why it is so important to get a good night's
It's funny
sleep.
you say that, because sleep takes up a third of our life. And ironically, in this culture, we have become so bombarded with the idea that sleep is almost non-essential. So there has been for years a glorification of people in different professional sectors, whether they're trauma surgeons or investment bankers or or radio talk show hosts or media personalities to be able to try to function on as little sleep as possible. I read something in today's paper, interestingly, not to go off on a tangent, but the new coach of the Washington Redskins, Jay Gruden, actually makes it mandatory for his staff and his players to get enough sleep, because there was a description about how the previous two coaches, Mike Shanahan and Norv Turner, or two of the last two coaches, would go to sleep very late and be notorious for showing up extremely early at the facility to go through game film and training and so on. And we are now seeing, pieces of this, trickles of this in popular culture. We hear about professional athletes who use CPAP, like Shaquille O'Neal. We hear about professional athletes who have died of sleep apnea, like Reggie White. The point is that what I was saying earlier is that if you're a type 2 diabetic, or if you have high blood pressure or pre-high blood pressure, or if you're overweight, or if you have memory loss, if you are educated, whether it's by your cardiologist or your primary care doctor or by the sleep doctor that you go to see because you make it there the first time that you're referred, about the health consequences of untreated or improperly treated sleep disordered breathing or sleep deprivation, that's ultimately what's going to move the needle in people potentially buying in on, hey, you know what, I got to do what it takes to make sure that I get treated properly.
Absolutely. 440-2665 or 1-800-940-2240. What are your questions about sleep disorder? Buck joins us from Glen, Virginia.
Glen, Virginia, but that's okay. Thank you for taking my call.
Thank you.
Your guest stole one of my talking points. I was going to remind all the macho men out there that Reggie White of the Green Bay Packers died of sleep apnea, so it's a serious problem. I had, for years, I almost got fired at work of nodding off, and I did a sleep study, and the two things that have saved my life is, A, Newby. It was prescribed by my doctor, and that helps me stay awake during the day, and I sleep at night. And the other thing that really helped me is I got a oral device made by my dentist that keeps I think he described it earlier, it dislocates your jaws, and it helps me sleep, and I don't snore anymore.
Okay, let's let the doctors talk to Dr. Newby.
Let's ask one question. Did you, when you had this mouthpiece made, did you have another sleep study to demonstrate whether or not it was actually controlling the actual apnea process itself?
Are you asking, did I have a follow-up?
Yeah, follow-up sleep study after the
mouthpiece
was made to make sure that it was actually controlling the degree of apnea you have?
No. I just told the doctor that it worked, and between that and the new vigil, I get a good night's sleep, and I stay awake during the day.
Well, the only question would be is whether or not, sometimes things can get seemingly better, because the question I would have is, why would you need the new vigil if it was actually controlling the problem completely? You really should not, at least in my mind, and Dr. Barot can kind of chime in on that, you shouldn't need a new vigil to stay awake during the day if, in fact, the mouthpiece is completely controlling. I'm not saying it didn't get better, and again, we're just speculating here, but I do have some concerns to make sure that it is, in fact, actually controlling the problem.
Dr. Barot, you want to respond also?
I think you're dead on, Dr. Newby. And Buck, I'm glad you're better. But what I would say is, something that I've told patients before when they tell me, "Oh my God, I feel so much better. Why do I have to bring my machine in so you can check it and download it?" Is I tell them that, hey, some PAP is better than no PAP. But that doesn't mean that you're optimally treated. And that's why these newer devices, the auto-titrating PAP machines, they have the ability, if the doctor prescribes it and knows how to read the download, they have the ability to almost substitute to a certain extent for repeat sleep studies all the time, because they can tell you beyond just usage, which is what insurance companies are interested in. They can tell you about the actual outcome. They can tell you about results.
Actually working and what the results are.
If
so you would encourage him to get another sleep test maybe?
And just to finish that point. So, for instance, if during your sleep study, the gentleman earlier described that he was told that he struggled to breathe or stop breathing 293 times in a night. And so if you do 8 hours, that's a severe sleep apnea because it's over 30 times an hour. So let's say that in his case, he stopped breathing somewhere around 40 to 50 times, or 40 times per hour. Well, In this particular case, if he gets a CPAP machine, and the CPAP machine can tell you about the residual, what we call apnea-hypopnea index, he may go down from 40 or 45 to 20. And consequently, he feels like $1 million. But what if I can adjust the pressure further, adjust the leak in the mask further, adjust his treatment to optimize it so that he goes down as close to zero as possible, which is what we always try to do. And consequently, the Newvigil, which is a wake-promoting agent, which is one of the newer brand-name medications to help promote alertness, because the patent on Provigil, which was the first one, modafinil, wore out. But it's an expensive medication, and it has its own side effects. And Dr. Newby knows that some of these side effects are cardiac side effects, including things like palpitations, arrhythmias, high blood pressure, headaches, and so on. You may need the Newvigil, but chances are that the best step would be at some point in time, Buck, for you to go and get a follow-up sleep study with this appliance in place, because if the appliance really does help, the only thing that you know subjectively it helps with is snoring and daytime alertness. Right. Obviously, it hasn't optimized your daytime alertness because you're on the medication. But for instance, what if by 2 or 3 or 5 more millimeters adjusting forward, we can eliminate your sleep apnea or bring it close to eliminating so you don't need this expensive chronic medication? We've made an even better impact.
Absolutely. The phones have lit up. Let's talk to David in Chesapeake. Hi, David. You're on the air.
Hello. Can you hear me?
Yes, we can.
Oh, great. I'm a patient of Dr. Barot, and I just want to say he's done wonders for me with the CPAP machine. I had high blood pressure. I was dozing off, reading on the computer, work, things like this, and went in to see him, did the sleep studies. They took great care of me. I really appreciate it, and hope your basketball game's doing well.
I'm getting older, David. I appreciate it. And I want to promise you guys and the listeners, I did not plant David. So I appreciate the kind words, David. And I'm so glad that you're better. And that's ultimately, I mean, we're all in healthcare because we want people to be better. And to the extent that we can be instrumental in doing that, we're obliged.
Okay, David, thanks so much for the call. Janet joins us from Newport News. Hi, Janet. You're on the air.
Hi. Hello. How's everyone?
Okay. How are you?
Good, thank you.
Good.
I just want to say I love your show. It's amazing. It's very informative, and my husband and I, we wait every Friday to listen to another view.
Thank you. We love that. Thank you so much.
You didn't put her in, did you?
I didn't, I promise. But tell all your friends.
Of course. I have a question. Because my husband did a sleep study test before, and because I thought he had sleep apnea, but they said that he had idiopathic insomnia. What is the difference?
Okay, you know what? So for some reason, this is going to be a really good answer because Dr. Barot just really reacted.
I have to be very, very careful on how I respond to this. What you may be describing is idiopathic hypersomnia, which is a very fancy way of saying that we know you're sleepy throughout the day. We can prove that you are because we've done daytime sleep studies to prove that you are sleepy, but that you don't have narcolepsy, and we can't find evidence of something else like sleep apnea or limb movements or something else like restless legs. I would be very careful with a diagnosis of idiopathic hypersomnia. Is she still on the phone?
Are you still there, Janet?
Yeah.
Janet, does your husband have any other symptoms like snoring or interrupted breathing or headaches in the morning or anything like that?
He has, it sounds like he stops breathing at night. Yeah. And this is after the heightened, snoring. It's
That's
he'll get peak of snoring, and then it's it drops, and he sounds like he's not breathing.
Kind of like what we described earlier.
Yeah.
Yeah.
And you also, I'm sorry,
no,
but you also mentioned something about a possible lack of, what's the term? A short-term memory. He has so many problems with that.
I'm not going to ask you questions that would potentially get us in trouble, but what I would say is that not everybody is the same, and I'm not going to promote our practice. What I'm going to say is that it's very important, if you think that there is still an issue, to get a second opinion like you would in anything, because sleep apnea can be deadly and it can be very dangerous. From what you're describing, it sounds to me like he has classic, what we call hypersomnia or excessive daytime sleepiness related to sleep disordered breathing. Not all sleep labs are the same. Not all sleep doctors are the same. Not all sleep technology is the same. So, for instance, a sleep lab may have equipment that's not as sensitive at picking up some of these breathing disturbances. And we see this progression where, for instance, somebody's told that you don't have sleep apnea, but there are symptoms like snoring and headaches or snoring and daytime fatigue. And then 3 years later, they get a sleep study and they're told, oh, well, you may have borderline. And then 3 years later or 5 years later, they're told, oh, well, now you have a mild case.
So in giving Janet that advice, and for everyone, how do you determine where to go? I mean, should you wait for a referral from your primary care? Can you look it up in the you don't use the yellow pages anymore, but can you Google?
You can Google. You can look up. You can look up just about any. It's funny. I was talking to a colleague the other day, and I said, you're an MD PhD. How come on your business card you don't put MD PhD? She's in private practice. I said, there are hardly any MD PhDs in private practice. She said, Demi, I haven't found the need to do it. I probably should, but everybody knows it because it's on my bio, and all my patients look up my bio. All I would say is that you want to be able to research your doctor, his or her credentials, background, training, board certification. 95+% of people who call themselves sleep doctors, for instance, they may be good, but they're not fellowship trained in sleep medicine. And now with all this information that we've discussed today and the 100 times more information that's out there, it's important that when you're treating people for daytime fatigue or sleep disorders or snoring or what have you, that you're actually thinking about the cross-pollination of sleep problems with health problems, so that you can not only say, oh, yeah, I want to help you stop your snoring and you're going to feel like you're more alert, but I'm also interested in your weight or your blood pressure or your depression medications, for instance.
Yeah, just to chime in really quickly on that note, one of the things I've run into is I'm a firm believer when you practice in medicine is you have to look at the entire picture. So as I'm seeing a patient, I'm like, okay, I really think based on what I hear, I think you have a sleep disorder. That's, they may go off and through some insurance, because I used to really try to send most of my patients to Dr. Barot. But every now and then you get some insurance carrier say, okay, we got this contract, whatever it was, and then I get a report back and it says they don't have it. And I'm looking on like, very with a interesting eye to say, something, if it smells like a duck, it walk like a duck, it talks like a duck, it's hard for me to think it's not. And I have actually sent people off. And it's really up sometimes to us as physicians and family members and even patients to say, something, I really think something's quite not right here. Maybe I do need to seek the other opinion, because if it falls down that path, I just have a hard time sometimes letting that go, because as it relates to these heart conditions we have, and I have a lot of patients with heart failure that really I do believe in my heart of hearts that sleep apnea played a big major factor in that the decompensation of their heart, and that does impact. I've had people that got a lot better where the hearts actually returned to function to normal from really being weak as a result of pure treatment of sleep apnea.
Dr. Barot, let me ask you a question too. I went to pick up my husband from a sleep study the night before, and the doctor looked at me and said, I can tell from the shape of your face that you have sleep apnea.
Was it us? Because we do that all the time.
Really? Is that true?
You can tell. There are craniofacial, what we call characteristics that make it more likely that someone might have sleep apnea. As an example, in the last 3 years, in the journal Sleep, which is kind of like the Bible periodical for sleep clinicians, there was a very nicely done study that compared the severity of sleep apnea in Asian men versus Caucasian men. And one of the anthropological classifications is specific to Asian men, and one is Caucasoid is specific to non-Asian and non-African American patients or people. So the study actually demonstrated that normal weight Asian men tend to have more severe sleep apnea than obese Caucasian men, and it has to do with things like a small mandible or jaw, a reduced distance from the mandible to the soft palate, which even a few millimeters can make the airway more collapsible, narrow nasal passages, a smaller neck, and consequently potentially more constriction in the upper airway. African American men have a disproportionately high incidence of usually undetected sleep apnea because they have a larger base of the tongue, they have a more thick muscular neck to constrict the airway, they have inflammation in the nasopharynx. So it's not a coincidence that African American men also have a higher rate of things like premature heart disease, diabetes, obesity, and so on.
It's all this big circle that connects.
It is,
connects.
And I don't want it to sound like, I think sleep is the key to everything. Sleep is a part, but when you think about, for instance, health and wellness, we always focus on diet and exercise. We don't pay attention to sleep. Just focusing on diet and exercise is myopic. You're not taking the whole picture into consideration. If you sleep well, after your sleep disturbance is addressed effectively, then yes, you should also be watching your diet and exercise just as carefully. But so often, as a culture, we've become so accustomed to thinking, for instance, that you have to be morbidly obese and snore like a freight train and have heart failure to have sleep apnea. Well, there was a time when, for instance, you had pre-heart failure or pre-hypertension, and you may not have necessarily been as overweight. People aren't born morbidly obese all the time, right?
Can children get sleep apnea?
Absolutely, and it's very common, and it's funny because the most common symptoms children have are a little different than those of the adults, where daytime sleepiness and morning headaches and loud snoring are symptoms in adults sometimes. Children tend to be mouth breathers. They tend to be inattentive, impulsive, hyperactive, and consequently so. Inattention, distractibility, impulsivity, and hyperactivity are, by the way, the four cardinal diagnostic features of ADD or ADHD. So they get slammed with ADD medications, and we've had kids come into our practice who we got off 1, 2, 3 medications because we treated their sleep disorder. When we screen, whether it's in school or daycare or wherever, or at home.
What makes the airway collapse? I mean, why does it happen?
Yeah, that's probably the gazillion-dollar question, but there are risk factors, right? Weight is one risk factor, but so many of us now in the field think that weight is not a primary risk factor as much as we thought it was before. That in fact, it isn't necessarily always that obesity causes sleep-disordered breathing. Maybe sleep-disordered breathing worsens or triggers obesity to be difficult to treat. But when you look at the causative factors, there are anatomic factors like the shape of the jaw, what we call cranial overjet, the actual way that the maxilla and the mandible align, the top jaw and the lower jaw, the size, caliber of the upper airway, the inflammation in the nasal passages. For instance, you can wake up with nasal congestion as being your prominent symptom for sleep apnea because that causes, because of a partial or complete obstruction in your nasal airway, it causes mouth breathing. So we don't pay attention, for instance, in children as much as we could to things like mouth breathing. And one of the first questions that good clinicians ask is, does your child breathe through his mouth or her mouth when he or she is sleeping? All of a sudden you ask the next question, does your child have issues with attention? All right, does your child have behavioral problems? Did your child have recurrent illnesses because it suppresses the immune system?
Because chiming on that point, that it really is important to note that obesity is not the issue per se. I mean, I think if you have it and you have the symptoms, of course, that's one thing to look at. But just like we talked about earlier off the air, I mean, I have a host of people who are thin as a rail who have severe sleep apnea. So a lot of times people have this mindset and this idea that if you're not obese, you won't have it, so don't look for it. But that's not true.
That's exactly right. There's a nice YouTube video if anybody wants to check it out. I remember seeing it some time ago of a very thin Asian man. I mean, thin to the point that you could see his ribs and you could see his musculoskeletal structure.
Wow.
And he's lying down, and you can actually see, and the guy probably has a body mass index of 16 or 17. And you can see as he falls asleep, he starts to have these periods of apneas for 60, 90 seconds at a time.
Wow.
And the fact that he's Asian and has that craniofacial structure is his primary risk factor. That being said, the vast overwhelming majority of folks who have a body mass index of 30 or more, which is what we'd call borderline obesity or obesity, have sleep disordered breathing.
Okay. Well, guess what, gentlemen? We're out of time.
Man,
it just flies by so quickly. Absolutely. But we will put your website on your web address on our website, anotherviewradio.org. And Dr. Newby, we will see you again in about 3 weeks or so.
Look forward
with
to
another health topic. And we will be right back. Just the beginning of this song, Nobody's Supposed to Be Here, which is the name for Deborah Cox. She's going to be downtown tomorrow night at Pride Fest. She is the major performer at 5 p.m. on the main stage at Town Point Park. So everyone come on down to the 26th annual Pride Fest. Tonight there's a huge party in Ghent given by Decorum, so you can go start the celebration there and then come on down to Town Point Park tomorrow. Our theme music was composed and produced by Jay Sinnott, and Lisa Godley is our show producer. Victor Bowen is our audio engineer, and special thanks to Hearsay producer Morgan Chase for giving us a hand with the phones. I'm Barbara Hamm Lee. Have a wonderful weekend, everyone, and let's get together again next Friday at noon for Another View.